Uh, Very good afternoon to one and all participants who is present here. And I welcome our resource person, Dr. Srikesavan Sabapathy, who has done his bachelor's from Government Physiotherapy College, Tirchi, and then master's, and also did his MSc Medical Rehabilitation from University of Manitoba. And currently, sir is working as a trauma inpatient physiotherapist in Major Trauma Center, JohnRadCliffe Hospital, Oxford University Hospitals, United Kingdom. Sir is going to have a guest webinar on the topic major trauma rehabilitation. So we are honored and privileged to have you in this webinar for the students of physiotherapy profession across India and also the clinical therapist. So on behalf of Charutat University of Science and Technology, I welcome you for this session. Hope that all the students and clinicians and other participants would get benefited out of this webinar. Sir, over to you, sir.
Okay, thank you very much, Bala. Good afternoon to all of you, and apologies for the delay in starting. There was a power cut, so we really can't fight with that. Thank you so much for staying, and thank you for joining back again. As Bala introduced me, I work as a trauma inpatient therapist at one of the hospitals in UK. And this is a major trauma center, and I'm going to explain a little bit later on what a major trauma center is and how it is different to other hospitals. So I started my career, did my bachelor's degree in the Government College of Physiotherapy, where I got very good exposure with patients and where I developed a strong exercise-based foundation for myself. And then I went on to teach in Bangalore at the Kripanidhi College of Physiotherapy for around 5 years. And then I moved to Godhra, where I worked at the Srikesavan Sabapathy Physiotherapy College. That's where I happened to meet Bala, and we were colleagues, and we had a very good time there. And then Bala went on to become the first principal of CHARUSAT. And I visited last time, and it's a great institute and a model institution to be followed in other parts of the country. Going into the lecture itself, so the first thing that I wanted to outline is the content and the learning objectives. I'll tell you what I will be covering and what I won't be covering. So first half of the lecture would be mostly the origins of major trauma, because I live in England and I work in England. Mostly that content that I will be delivering, but it will be these processes. These processes are same for other countries as well. And then guideline development. The word evidence-based medicine or evidence-based physiotherapy itself is thrown around a lot. Now, though it's a simple sentence, the background to how you develop a guideline and how much of work that goes on to it, and how to actually bring it to patient level and how many years it takes is a lot. So a little bit I'll touch on that. And then what were the recommendations of the NICE guideline itself, and what the major trauma networks are. And I'll be touching on MDT's multidisciplinary. We all know that we cannot take care of a patient by ourselves. So it is a team approach, and the formal, what MDT means. And then the rehab aspect. And I would also like to the Indian perspective of trauma. And either in between or towards the end, we'll be touching on the literature that I've based all my presentations on. And towards the end, we'll discuss a case study. I'll explain the case, and then it's a fictitious case, purely fiction, not slightly touching on patient, but fiction. And then we can all contribute to what you would be doing and what I would be doing, and it would be very, very useful to get different perspectives from students, from teachers, from everybody. It's based on how we will be managing. Okay. And going to the next slide, since people will be coming in and dropping out due to your convenience, I did not want anybody to miss the acknowledgements. I would like to thank all my teachers who are responsible for what I am today, and my continued pursuit for knowledge I attributed to them. And then colleagues past and present, especially Bala. We had a wonderful time in Godhra, a small place, a calm, a quiet place, and I would consider that as one of the best periods of my professional life. We got a lot of work done. We got to read a lot. And then my colleagues new colleagues who have met on social media, every interaction that I have with them is actually a learning experience for me. And students from past and present, I don't know how much my students benefited from my lectures, but I benefited a lot from all the interactions that I had with my students, starting from the preparation of lectures to delivery of lectures, and then having those discussions with them. And since I have not worked in India for a long time, I left in 2009, and not worked in Tamil Nadu for a long time. I want to thank my friend, my schoolmate, and Dr. Kumaresapathy is an orthopedic surgeon. He's an associate professor in orthopedics at the Karur Medical College. I think he was in the KAP Medical College. So we are close friends, and he gave me the context of the current trauma in Tamil Nadu. I also want to thank Dr. Murthy. He is a physiotherapist at the JPN, Jayaprakash and Apex Trauma Center in Ames. Now, this is when rankings go, Ames comes as the #1 institution in the country for a long, long time. So I had a good conversation with him yesterday to understand the perspective of how trauma is managed in India. Thank you so much to you, sir. And to all the participants today for joining. If not for you, this lecture doesn't happen. Thank you so much for joining. And let's move on to the next slide itself. And what I wanted to let you know at this time is towards the end, we'll be opening it up to questions. So if you can kindly write them down as the slides go. Otherwise, we'll be forgetting the questions. And towards the end, if you can ask them, Bala will be reading it out, type it in the chat box. Or I'm not sure how Bala is going to organize that. Maybe you can speak out or type it in the chat box, and then I'm happy to answer. If I don't know, I will get back to you on that. But if I do know that, we will all share it right now. Okay, some messages coming in. Yes, okay, yeah. So first of all, I wanted to touch a little bit on the origins of major trauma care in the UK. Everything good has to start somewhere. So one of the seminal studies was, this is not a trial or anything, but it was it's actually an interesting study. It's a retrospective study of around 1,000 deaths from injury in England and Wales. There was a similar study done very recently in India. I'll come back to that towards the end of the presentation. So basically what they did is, so what they evaluated, 1,000 consecutive deaths from injury in 11 coroners. Coroners are the pathologists who do the postmortems, districts in England and Wales. And these deaths were reviewed by 4 independent assessors who actually studied the necroscopy reports to identify what could have been prevented. Could these deaths would they have been preventable? That's basically what they wanted to look at. And then of the 415 patients admitted to the hospital alive, around 102 deaths, around 20% of the deaths by all the 4 assessors, it was judged as they could have potentially been preventable. And then when they try to look at if 3 people take 1 away and then 3 assessments, then it rose to around 33%. Nearly 2/3 of all the non-central nervous system deaths were judged to have been preventable. Now, as a study design itself, this doesn't tell us a lot because the end outcome is death here. So death is the outcome. So obviously we know that either there were errors committed or there was it wasn't preventable. But what they found out is this is a very large number. So imagine if this is actually published in a newspaper today, the hue and cry that will happen. So what happened is back in 88, this was done, and it was published in 88. So maybe it was done in a year back or something. And something had to be done about it. And what happened is, England, everybody loves the committees. So a working party was formed in 1998, which was chaired by Professor Sir Miles Irwin at the RCS, and they made a few recommendations in how trauma should be managed. So some of the recommendations that they made were to enhance the pre-hospital care, ensuring appropriate medical intervention. When we refer to the pre-hospital care, it is at the site of the accident or the injury, and the people who are involved in handling them there, and then transporting them to the facility itself. So the pre-hospital, so appropriate training should be given. So when you enhance pre-hospital care, it involves training, it involves safe manual handling, it involves appropriate equipment, and then rapid transfer to the best local facility. Via ambulance, and then the next point itself mentions the use of helicopters. Now the use of helicopters is common in England now, and in a lot of the developed countries. When we work in the hospital and if we hear the helicopter noise, I mean, when we see it on the road, we look at it in awe, like it's a nice thing. But when we hear the sound of the helicopters, we know that it's not a good thing for our patients. And then adopting the ATLS principles. ATLS means Advanced Trauma Life Support Principles. Now, this is not only for the trauma practitioners, it's for the emergency practitioners as well. And this is a training that is done across India a lot. And the origins of it is, if you Google it, in the late 70s, it happened where the Striner, I think, yes, he was flying back from a conference in California to Nebraska, and then in his own plane with his wife and 4 children. And he crashed the plane. And the wife died instantly, and then the children were there, and then he tried to go to the local hospital, and he was shocked with how the local hospital was not prepared to treat these emergency patients. And then he started at the University of Nebraska, he started developing the ATLS, and it is followed throughout the world now, the training itself. I had a quick chat with one of our senior house officers yesterday, and most of our trauma registrars have ATLS training, and a lot of the trauma doctor, the senior house officers to also do that. And in India, it's widely, the training is given widely. And then they also recommended integrating trauma services within and between hospitals. So integration means in a hospital, the neuroscience will be in a different place, and trauma, orthopedics will be in a different place, general surgery in a cardiorespiratory in a different place. So what they, and then running around to get the care from each team, it was time consuming. So that's what they meant by integrating the services within the hospital. And then between hospital, if there's a smaller hospital, if they want access to the expertise and care of a larger hospital, that should be integrated. And one of the major things, as early as in 1988, what was identified was investing in rehabilitation services. That's where we come into the picture. Like it is understood long back and constantly understood that it's not all about stabilizing the patient during the, I mean, that's so important, getting the patient, saving the life of the patient. and then fixing the patient. But then what should be understood is that the patient has to live a life from there. So rehabilitation plays a huge role, and it was identified in 1998. Now 2 or 3 decades later, still reports are there where professional organizations are still advocating for better rehab support in the acute setting and in the community setting. So we are still having to fight for that, because in the larger scheme of things, saving the life of the patient becomes more of a priority, providing some quality of life and bringing them back into the mainstream economic force, and those kind of things are not taking priority. And then one of the key things that they also mentioned is that it should be numbers count a lot. Numbers and data, that's where we lag a lot in India. Auditing and researching injury and the systems of care itself. Okay, the major trauma system is being introduced. Now, is it working? Is it fit for purpose? Is it financially viable? Is it doing good for the patients? Now, unless you study these systems of care, you're not going to know whether they are working or not. Moving to the next slide, a lot of the major trauma work was actually done in the United States initially, and UK, I mean, based on reports, they say that they were late to the game. And a little bit of disturbance there. Yes. Okay, yeah. So, Bala, I think it's Kamlesh. Can you mute your audio, please? Yeah. Okay. So this is one. I will. I have mentioned my email ID towards the end. If you email me, I will send you all the literature. Now, there's another one, the Major Trauma Outcome Study, Establishing National Norms for Trauma Care. I won't go much into it, but basically what they did is from 1982 to 87, there's a 5-year period, or they all the North American hospitals, around 139 North American hospitals, they submitted information to provide a database of 80,000 trauma patients. Now, when you have a database of 80,000 trauma patients, you can actually study what is happening, why are they here, what is the severity of the injury, and then when were they discharged, how much therapy sessions they got, and what kind of procedures were done. So if the data is there, you can study it, and then you can make changes. If there's no data, we will be under a false sense of confidence that whatever therapy we are doing, whatever treatment we are giving is good for the patient. Now, this year, what happened is there was an editorial 30 years after the Major Trauma Outcome Study, benchmarking trauma center outcomes. Now, one of the, I couldn't get a hold of this article. It's a paid article, and I'm working from home. If I go to the university, I'll be able to get that. I'll be able to share the abstract of that along with an email if you ask for me later. We really don't know what they reviewed 30 years down the line on this major seminal study. And then speaking about trauma in UK, we have a bimodal distribution. A bimodal distribution means 2 age groups, and it's on either extreme kind of thing. So the first peak is under 20s, and then we have the second peak in around 65 and above age group. You can attribute it to some of the first 20s are very active, and that could be the reason. And then the 65 and age group, as people grow older, bones become a bit weaker, in women osteoporosis, and even smaller activities or a minor fall that in 20 when we don't get an injury, when that happens in 65, they get a fracture. So there's a bimodal distribution. And under 45, for all people, this is the single biggest killer, is major trauma. Now, some people die out of because of major trauma under 45, and those that survive, some of them go on to have permanent disabilities. So it's given a lot of importance. And in 2000, the National Audit Office, they said that they did a bit of review, and they said that there's a lot of variation depending upon where you live in England in the amount of trauma, in the quality of the trauma care that they get. Now, this was unacceptable. In one center, patients are being treated well, and in another center, patients are being treated in a different way, substandard care and standard care in another place. Now, whether this is intentional or unintentional, either way, the quality of the care is suffering there, and there's huge variation. Now, why I'm mentioning about all these reports and the years is just to highlight how long it takes for systems to come into place. And then another report in 2007 said that around 60% of major trauma patients received a standard of care that was less than good practice, with avoidable deaths still occurring. That was again unacceptable. And then this led the National Audit Office to actually recommend the development of regional trauma networks in England. That's where the major trauma networks, the word started getting mentioned, and that's where they started. And to give you a context, it was started off in 2007, and when the major trauma networks came live, it was in 2012. And there was a 5-year gap there itself. You might ask what people were doing in 5 years. They were actually getting ready, doing all the background work to get this in place. Now, another important paper, at least to me, to prepare this lecture, is an article by Mr. Graham Sleet. He is a consultant in our trust, and Professor Keith Willett, who was responsible for revamping the whole, or initiating the whole major trauma system. So he's a professor at the University of Oxford, professor in orthopedics. And so in 2011, in this article, if you read, rehabilitation, again, it mentions, it gets a mention there. Rehab is the greatest challenge in establishing effective trauma systems. So historically, they have been poorly supported. It's because the patient is fine, talking, they've been fixed, fractures are healing, trauma is healing, but what next? So this level of interest starts trickling down, and the interest becomes very poor when it comes to actually rehabilitation. If you think about it, after a patient is discharged from the hospital or from your care, how often do you think about them, whether they are managing their day-to-day activities, or whether they went back to their leisure activities, whether they went back to work? It's not very often, because we move on to the next patient. And Professor Willett, he was the co-founder of a unique 24-hour consultant and resident-led Oxford trauma service at the JohnRadCliffe Hospital. And way back in 1994, at that period, they started that, the 24-hour. Now, where is 1994 and where is 2011? If you look at that, how many years of hard work had to go on there to actually bring these systems into place. And then Professor Willett also was appointed as the first National Clinical Director for Trauma Care in April 2009. And his responsibility, and his and his team's responsibility, was to radically improve the care of older people with fragility hip fractures, and then also to establish the regional trauma networks and major trauma centers. And huge credit to him and his team. By 2012, both reorganizations and care pathways were in place, and are now credited with marked improvement in patient care and survival. So 2012 onwards, all of this came into place. Okay. Now this is a map of in England, the regional trauma center, the major trauma centers. I don't know how much you can see this, but there are 27 major trauma centers in England, and I think there's one in the pipeline to be started in Wales, in Cardiff, and some of them are combined adult and peds. children's, and then some of them are separate adult and some of them are separate children. So if you look at this, the JohnRadCliffe hours is a peds and adult. And if you look at the map itself, there's a cluster here. This is London. Primarily because of the population itself, there are 4 major trauma centers in London. And then also they are divided into regional networks. I won't go too much into that. Like if you take the 4 hospitals in London, they are called as the Pan-London Trauma Network. And then ours is the Thames Valley Trauma Network. What it involves is the major trauma center and then the surrounding hospitals. So there are other larger hospitals where they come for major trauma expertise to the JohnRadCliffe Hospital. Okay, and then I also wanted, the next 5 slides are borrowed from a TAN presentation. It was in the public domain. TAN is the Trauma Audit Research Network. Now, as I mentioned again, if you don't count numbers and if you don't look back at what you're doing in terms of data, you're not going to be able to make improvements. So the TAN plays a huge role in collecting data entry, and then data analysis itself. So every patient who comes to the trauma center gets mentioned. There is a dedicated team of excellent staff who actually input this data. It's the largest European trauma in Europe, a trauma register, around 650,000 patients. That's an extra 0 there. Injured patients are entered there. Okay, and basically what they do, it's clinically led, academic, lot of academic work is done, a lot of publications are done, and it is independent. Okay, and then what has changed, like what the care before major trauma centers were brought into place and before. So basically on the scene, the patient triage, if the emergency medical technicians, they identify the patient as positive to major trauma, they immediately then they are transported to the nearest major trauma center. Now in a major trauma center, they have to be received by a consultant-led trauma team. I think the guideline is within 30 minutes they should be seen, and then there should be the availability of immediate operating theaters. There should be the availability of all specialties like neuroscience, general surgery, cardiothoracics. These specialties should be immediately available, and then an immediate CT scan. If the head, if there was a head injury, they should have that CT scan within 30 minutes. And then interventional radiology and ITU access should be there as well. Now this is, the patient is brought from the scene of the incident directly to the major trauma center itself. Now if they triage differently, you can also come as an indirect transfer from another hospital to the major trauma center. Okay. Now if you take the mechanisms of injury, vehicular accident contributes to around 20% of the injuries, and then falls, under 2 meter falls. I'll come back to that. Penetrating injuries, 2%. A lot of stab injuries happen in London and around. So that contributes to that. And then blows. Blows are normally it can happen during contact sports. And then falls above 2 meters. If you climb on a ladder and fall, or we get a lot of patients who are roofers who actually fall down from heights like that. We do also get people who try to self-harm themselves by jumping off a bridge or a apartment or a block. And 58% are those who fall. Now this contributes in the bimodal distribution towards this end of the older adult side. Now why would anybody have a fracture for if they fall from a standing height? or on a stool or something. So it indicates the quality of the bone as well. That's the bulk of the patients there. And then in terms of the parts of the body where the injuries happen, head injury is 25%, and then the limbs constitute around 33%, the spine. So this combined, the limbs and the spine, we get them in the trauma wards, around 50% of them. Sometimes chest alone, they go to the cardiothoracic wards, and head injuries alone, they actually go to neuroscience. But you will get patients who have polytrauma, where mild head injuries will be there, where they can be managed in the trauma wards itself. Okay. And another concept that is that works out in England is providing a best practice tariff. Now, a best practice tariff means, to put it in simple words to understand, for each, the NHS in England, the government pays money for the care of each patient. Now, what they said is that if you provide, if you have a best practice list, and if you satisfy that, then you get some extra money. So that is basically what best practice tariff means. So for hip fractures, what they did is, if I'm giving you random numbers here, so if £1,000 was the care that they were going to get normally, so what happened is, it was reduced to around maybe £800, and then if you satisfy all the best practice, then you get £1,500. So what this does is, it gives a lot of motivation for hospitals to satisfy those best practice criteria to get that extra money. That is to put it in very, very simple words. Now, I'll be coming to the ISS, the injury severity scores in the next couple of slides, but won't dwell a lot in that. So for level 1 patients who have moderate trauma, with an injury severity score of above 8, okay, above 8, under 8 would be minor. So moderate trauma, £1,500 is what they get. And then for major trauma, £3,000. So all of the hospitals, we try to work hard to actually get that amount to actually run the hospital. That's where all the money comes from. And then the best practice tariff itself is worth 45 million per annum. And then last year, 10.5 million were missed in payments. Now, this is a pot of money staying there, where you could have actually worked harder and satisfied the criteria and got that amount, but you couldn't. Okay, and then coming to the NICE guidelines development, a lot of the discussions that I have and with colleagues and with students is why is everybody talking about evidence-based guidelines, and is it easy to practice, is it difficult to practice, and basically we owe it to our patients to actually give them the best care that is possible, not the best care that I think is good, or my colleague thinks is good, or the next colleague thinks is good, but based on review of literature, review of the evidence, and then collating all of that evidence, and then bringing it out in the form of a guideline itself. So we in England, for majority of the conditions, we follow what we call as NICE guidelines. Now, these guidelines are developed by committees, and the thing is, as an individual clinician, you cannot run and look at the evidence every day to actually see a patient. You're getting a new patient, you cannot run back to the literature. It is impossible to do that. That's why we rely on guidelines. And then when we talk about NICE guidelines, we have the confidence that if we follow those guidelines, we have the confidence that those are evidence-based guidelines. And when we follow those guidelines, we are providing quality care for our patients. Now, for the major trauma service delivery itself, the guideline that we use is the NICE guideline 40. Now, early work started in 2013, and then it was completed in February 2016, and the last update was in 2017. So this is basically what I'm going to highlight is the method, the evidence, and the recommendation itself. Now, if you look at this guideline, I intentionally wanted to put this slide here. So the guideline development, the group, the full members. So what you want to look at here is it's not a committee made by just by one particular profession, and it is a group of professions, and all the stakeholders are involved, and they come out with these guidelines in a systematic way. So ideally speaking, for an evidence-based guideline to come out, it takes around 5 years, as in this case. And then you need updates when as evidence keeps generating, you also need to keep update. So if you look at this guideline group itself, we have I've put in orange Mr. Bob Handley. He's one of our trauma consultants. He was in that group. And then I wanted to highlight Karen Hoffman. She's a research fellow and occupational therapist. And then if you look at these, Stephen Bennett, he's a patient member. And at the bottom, there's another patient member. How often have we actually utilized patients in developing guidelines? The shift between what we think is good for the patient has gone, it has shifted, research has shifted from what we think is good for the patient to what the patient thinks is what we need to research and provide care for them. So if I cannot make a goal for a patient, it's the patient who should tell you what their goal is and what we want to achieve from a therapy session itself. So it's really important that at the point of guideline development itself, patients are involved so that they can provide that patient perspective early on. So if you look at the LIND Alliance patient partnership initiatives, there's a lot of work going on in England where patients are patients contribute to research design and research participation itself. So one of our professors, Professor Matt Costa, he was heavily involved in the LIND Alliance and the publications there. And if you look at the guideline development process itself, it snakes through like this, starting from this green and then going up to there, and then coming there. So we are starting from the red here. So that's the interpreting the evidence. That's the patient level care. Okay, determining the type of review question. Now you just cannot go and develop guidelines. You need a specific focus for that. So that's where your research question comes into place. Basically what you want to do is, okay, am I providing proper trauma care for patients? So something to that extent, you make a research question, and then you write an appropriate review protocol for that, and then specifying the review question. And then you also need to define your inclusion criteria and what analysis you're going to do there. Is that a crow? Is that a crow? Okay. Okay, and then once you have reviewed your protocol, this is something like the research process that you go through. A lot of you people who have studied methodology, you would know that. And then producing a search strategy and searching for the medical literature databases. And then once you have searched it, you sift through all of that to find out the articles that are going to, if anybody has done a systematic review, it's something like that that goes on in the guideline development process that may meet the inclusion criteria to answer your question. And then you obtain those full papers, and then from the full papers you extract the data, and then you apply a risk of bias tool for each of those. There are several risk of bias tools. The Cochrane tool is a standard tool. And then for each outcome that you want, you have to include the studies there. And then adapting and updating any Cochrane reviews and other published reviews that have been identified. And then including studies using the full papers against the inclusion criteria that you gave in the protocol, and then analyzing the results, and then assessing the evidence quality, by outcome. The grade evidence, if you Google grade evidence categories, you will get that. And then you come to interpreting the evidence. At the end, the committee's responsibility is to interpret the evidence and then provide us guidance, and we follow those guidelines. So if you think of this, so many people are there in the committee, and they have to go through all of this process. Now, and the review question itself, if you look at that, I particularly wanted to highlight the rehabilitation question that was asked to actually come out with the guideline. So in terms of rehab, the review question was, what are the barriers to providing early rehabilitation following early rehabilitation assessment? What are the implications for service delivery? So this was the question. Now throw this question into the steps that I mentioned earlier, and then follow the sequence. And you need to follow the PICO characteristics for the review question itself. So if you go with the population intervention outcome and the study design itself, people who have suspected major trauma and are using the health service, this is the population. Indirect population can be included if traumatic brain injury and spinal injuries can be included. And then early rehabilitation within 72 hours. If there are papers that are mentioning, we are going to look for those papers, physio, occupational therapy, speech, mental health professionals in the first 72 hours. But then a note is also mentioned that if there is limited evidence on early rehabilitation assessment, we will include papers that look at barriers to providing rehab, even if it was not early. So there are compromises made there. Now you make compromises there when you actually anticipate that you're not going to get too much literature there. These will be outcomes, these are the barriers that are identified in the papers, like inadequate assessment. If the paper mentioned that we didn't have enough staff to provide these services, staff resources, and then patient factors. If a study has mentioned that the patients were in significant pain and the first day assessment was unable to be done. So those kind of studies as well. And then the design itself is qualitative because you're basically looking at it, looking at the studies there. Okay, so that's how it is done. Now you will be surprised at when was this done? 2012, isn't it? Yeah. 2012 onwards. Yeah, you will actually see that. So what did they find? Basically, they found nothing. And one of the reasons they found nothing is because there weren't enough studies. So when they wanted to look at clinical evidence, there were no relevant studies. When they looked at economic evidence and for published literature in that, no relevant studies. Evidence statements, clinical, no. Economic, no. So as early as in 2012, there weren't enough studies in rehabilitation. Because major trauma itself is a kind of a new thing. Somebody asked earlier whether it can be a specialty in India. It's just that it's kind of a it's being done, but as a subspecialty itself, I would say it's 20 to 30 years old. And then what did they say? The recommendations of the Guideline Development Committee itself. I promise you that the slides will be less crowded as we go on. So the lack of early rehabilitation after major trauma, there are major factors underlying poor outcomes seen for major trauma in UK. So they're relating poor outcomes to actually lack of early rehab. And some of the barriers that are mentioned are staff also being unsure of the benefits of early rehabilitation. This is something that we are constantly having discussions on. Okay, the patient is feeling really ill. Should we get them out of the bed or not? Should we get them onto a chair? Should we leave them in bed? My policy has always been, unless a patient requires absolute bed rest indicated by the medical team, nobody should be in bed. Unless it's the night for resting, they should be out. But getting that message across is sometimes difficult because staff we are unsure whether they'll be safe out of the bed or not, and then lack of trained staff. there need to be, when you work in major trauma, there have to be competencies to gain, and it's unlike working in an outpatient setting, which has its own other competencies, but you need to be manual handling trained, you need to know where to hold, where to touch, what attachments to look for, and things like that. And then lack of an integrated care pathway itself, and in general, a low priority given to rehab. These are some of the things that the guidelines say. And then also rehabilitation, they identify that it's an intrinsic part of recovery, and they strongly mention that there's a paucity of evidence, and this should be emphasized, the lack of evidence. And as such, they made a research recommendation to focus research on identifying what barriers are existing in the UK NHS system to delivering rehabilitation effectively. I'll touch on that because we have a public healthcare system, and there is a private system as well, but overall, overwhelmingly it's a public system, but in India we have slightly different. So accessing rehab is more easier there. I'll come to that. And then the guideline development group also emphasized that rehabilitation should start as soon as possible, and then waiting is inappropriate. So we should never be that, okay, we don't have that information, we don't have this information, let's get this, work on this patient the next day. No, that would be not good practice. So we need to get the information, all of the information that we need, and then we should go in as early as possible. And the group itself felt that delayed rehabilitation may result in first of all, an inappropriate use of other resources. Now, one of the other resources is an extended length of stay. It is not only that, it also leads to complications which are complications of waiting, like pressure ulcers, joint contractures, and the psychological complications of depression, apathy, anger. It all contributes to that. There are, when I work with patients, I only find a minority of patients who want to stay in hospital even if they're getting better. A majority of them, they actually want to go home. So we don't want to delay that by delaying rehab sessions. And then the rehab services that exist across UK are very highly variable, for example, with respect to proportion of patients selected for inpatient care and the availability of home therapy, as well as in residential services. Now, this has been highlighted a lot, and even last year, the Chartered Society of, I think it's this year, the Chartered Society of Physiotherapists, they started a campaign on improving community rehabilitation services. I'm a huge believer of community rehab, where patients are being treated at their own home. Even if they have a lot of rehab needs, it can be safely delivered at home. And patients at home are empowered. It's their own environment. They find it easy to move around. And people who are not very cooperative in the hospital, they will be cooperating more there. There's always the minority who feel scared staying at home and getting the rehab home. But in general, that's what. So the CSP started a media campaign on, they started going to each and every MP, and it was a very concerted media campaign, a huge salute to them on getting community rehab. So in general, there's a lot of variation. Now, to mention a little bit about the injury severity score, I don't want you to go through the whole slide here. The ISS itself was, the origin started off from the automobile industry, where they wanted to grade injury. So this paper, Edwards, 1974, if you look at that, some of the things that people wrote and did decades ago have stood the test of time. So still the ISS scores are used. And if you look at this, how they do it, anything under 8 or 9, I think, is not a major trauma. And then 9 to 15 is moderate trauma, and then above that becomes severe trauma. That's how the classifications are done. And if you look at this, how it's done, it's a formula. The ISS, if you see, if there's there's a case study, a man was injured at work and he suffered multiple injuries, and then fracture of the mandible, body of the mandible, he gets 2 points for that. And fracture of the low end of radius, 2 points. And then for his fractured ribs with a flail segment, 4. Abrasions, which are wounds all over, 1. Neck pain, there was no obvious injury there, but he had a little bit of pain. So if you, and then they square all of these numbers. They square them, and then they come to 24. Now, why they square and everything, you'll have to go to this article. I'm very poor at mathematics. I take it as the ISS score. And later on, I'll be explaining an Indian paper, if you can remember what the ISS score is. And the pathway itself, what happens after an acute injury. So at the bottom here, you see that acute injury happening. So it goes all the way there, and then they go to the major trauma center or a trauma unit. And then from there, they go to the post-acute care, ward-based, and then they could go to rehabilitation, level 3 inpatient services, a regular ward where rehabilitation is done. And then they can be discharged. If you see the blue line and down there, that's the home or the community. They can go to supported discharge, hospital at home or early community rehab, and then start reintegration into the community, and then long-term support and getting them back to work and things like that. Now, there will be some patients who will not be able to go through this green path here. They will actually require more care. Their needs will be more. So that's where you go into a hyperacute rehabilitation ward, which is like our ward there. And then you will start off trigger off specialist rehab prescription. I'll mention that in the next couple of slides. So from the hyperacute rehab center, a lot of our patients recover well and then go into the community there to specialist community rehabilitation, which is basically community therapy there, and then they can be taken into the integrated care planning of getting them back into their life. But some patients actually have to go into specialist inpatient rehab from our place itself. They go in there, and these are levels 1 and 2A, and then level 2. High level care is required at tertiary care. A level 1 rehab center, we have one in Oxford. It's called the Oxford Center for Enablement. I think it's level 1, yeah. And suppose amputee rehab, bilateral amputation. We are not going to be able to, sometimes we have got them home, but they would. And then head injury patients, they actually go through this pathway. It's a pathway, okay? Okay, everything is fine. I've explained how the major trauma systems work and work. Now, does it work out? That's a huge question. So constantly you have to look back at your systems and see if they work or not. So this research paper came out in eClinical Medicine, published by the Lancet by Professor Moran. Changing the system, major trauma patients and their outcomes in NHS. They looked at what happened between 2008 to 2017. Now, I want you to recall the fact that the major trauma centers came into effect in 2012. So a few years before and a few years after that. So what they actually found out is that in an interrupted time series analysis, there was a significant positive change in the slope at one point. That was in April 2012 when the major trauma centers were actually introduced. So there are statistics given here, but in lay terms, in other words, an increase of 0.08 more survivors per 100 patients every quarter. So if you do the math there, the systems are actually saving lives. If you can save one life, that actually means something. Now, on the trauma rehab research front in UK, as I mentioned, it's new, but the Association of Trauma and Orthopedic Chartered Physiotherapists, I'm a member of that, and they are doing a lot of work in trauma research, trauma rehab research. Now, what they have done is the last 2 years, the Speciality annual conference, they do it actually in with the at the same time as the British Orthopedic Association annual conference. So that is like getting two groups together who actually have a lot of common interest. Now, and in terms of trauma rehab, we want trauma consultants to be talking the same language as the trauma physiotherapists. And but when I checked this time's Physiotherapy UK, which is happening in November, when I checked gave the word trauma, there were only 5 entries there. So even last year when I gave them same search, there was very little. So even in the national stage, in terms of conferences, there's very less research going on. There needs to be more. Orthopedics, it comes there. A lot of cold orthopedic conditions and that research is happening. But trauma orthopedics is not that much. And then the current, the CSP, what they did is I mentioned how patients dictate what kind of research they expect us to do. So this was a partnership between the CSP and the James Lind Alliance priority setting partnership. So patients, carers, and physiotherapists told us questions they wanted to ask where research could be made real difference to patients. So basically what patients wanted to know is, what are the physiotherapy treatments? And you'll be really surprised. They wanted to know what self-management is. Now that's where we need to put our education hat on, and then home exercise therapy, and then how patients can manage their conditions themselves, and then improving health and preventing the disease and injury, and how services are accessed and delivered. These are some of the areas that patients want us to research on. It is not what we want to do. Why do we do research? At the end of the day, it's not to have a bound copy or publish and everything. It should reach the end user, which you can call that process called as knowledge translation. Okay, and then hyperacute care presentation will be another 20-25 minutes. Is that okay, Bala?
Yes, sir. Yes, sir.
Okay. Yes. People might drop out and then come back. Okay. So hyperacute care and rehabilitation. This is the kind of ward that I work in. What it refers is to the very early stage of rehabilitation. These patients are stepped down from critical care and high dependency units, but still they have unstable medical. So their intensive care needs are met with. We have one of our colleagues who is a major trauma center critical care therapist. She manages a lot of these patients, and then our ITU therapists themselves, they manage these patients as well. And then once they step down to our ward, they give us a handover, and then we start managing these patients. So they are stepped down from critical care, but they may no longer need to be under the direct care of acute medical and surgical teams, but still require those specialists to be available immediately if needed. Now, in the past, just before the MTC systems came into place, they were repatriated to non-specialist or non-rehabilitation beds, often in a different hospital. So this was considered inappropriate because their needs for acute care as well as for specialist acute rehab and specialist care were not met in those settings, and now in this hyperacute care setting, it's being met. Now, when I was looking at the literature, now for people outside who look at the NHS, everybody thinks that, okay, it's the National Health Service, so everything might be uniform all across England in all the hospitals. Now, that statement would be the furthest away from truth, because sometimes a good practice that happens in a different ward doesn't get translated to the next ward. So each hospital have their own ways of organizing beds and things. Some major trauma centers have dedicated major trauma beds, but ours is a mixed one where you have non-major trauma and major trauma together. This gives us an opportunity to have experience in both ends of the trauma spectrum. Okay, now coming to, you would have heard the word multidisciplinary team being thrown around a lot. In England, in the NHS, all care is delivered via a multidisciplinary team. No one is more important than the other, though at intervals of time, one person's expertise takes precedence over the other person's. But it's care delivered by a whole team. Now, I like to put the patient and the family at the center of the whole MDT team, shared decision making, talking to the patient and explaining to them, this is what we intend to do, this is what are your views on that, and as casual as a conversation. Good morning, Mrs. Jones or something. To benefit your chest, we are going to get you to sit on the chair. Do you think that that's a good? Most of them will say that's a brilliant idea, and others will say I'm very comfortable in the bed. Please get lost. So you can see both spectrums there. And then we don't leave them there. We start explaining the benefits. But the patient should be at the center. And then we have the acute surgical and medical teams. The trauma surgeons, they fix the patients and they come and they follow these patients during ward rounds every day. And as the days go by, their input becomes less. And the therapist and nursing care starts from day one. The therapist's input becomes more. But then for reviews, again, they come back to the trauma consultants. And then the medical teams, we have the geriatric ortho teams. These are very critical team and a hugely valued group of staff. The orthogeriatricians for major trauma and for non-major trauma, there's a lot of evidence suggesting that patients who were assessed either pre-op or post-op by the orthogeriatric team, their survival rate improves. So we have an excellent team where if we have any questions, we go to them, they immediately give us answers, and then we are able to manage them. So what it gives us as therapists is a safety. If you see a patient who is unwell, you know what to to look at all the physiological parameters, but at some point, if you get stuck, you can actually go back to the doctors there. And then we have the therapists, the physiotherapists and the occupational therapists work closely together in major trauma. A lot of the time we do our initial assessments together. There's a lot of shared work going on there. And it's really important that both teams sync together and work together to provide, because something that is not on my mind would actually be, because we are trained in different ways to look at different things for the patient, and eventually the end benefit to the patient is what's important. And then the nursing care itself, I want to mention a lot about the nursing care. It's really important that major trauma patients get nursing care by nursing colleagues who are trained in major trauma. You will see a difference. I work with a wonderful bunch of nursing staff who have really good expertise in trauma care. Now, one of the reasons why I mentioned that is we go to the patient for, just imagine the trauma surgeons come and talk to them and 5 minutes after the surgery, and then they go away. We go there, therapy session for half an hour, and then we leave. It is actually our nursing colleagues and nursing assistant colleagues who are with these patients throughout the day, 24 hours in different shifts. They know more about the patient than any of the other MDT group, MDT professionals. So talking to them would be the best way to get input about the patient, how they are doing, how they are participating, how they are chatting, are they eager to go home, or are there going to be a lot of barriers. You'll get so much of information just how with the nursing staff. Okay, and then in addition, and then I wanted to emphasize on the rehabilitation coordinators. Now, these are specialists. They can be either physiotherapists or occupational therapists, or there are rehab coordinators who are advanced nurses as well. Their role is very integral and really important. we have an excellent team of rehab coordinators. Now, one of the things that they do is, now as the ward therapist, we tend to concentrate only on the therapy session there, our physical, and then the goals localized to there. But what the rehab coordinators do is they coordinate all of this around. As the team, as the word indicates, their job is to actually coordinate a lot of this stuff. If a patient requires a level 2 rehab or level 1 rehab, they immediately start communications and get that paperwork in. And yes, so basically their job is to coordinate everything. Normally, and they have very quick access to the surgical team and the medical team. So if we have doubts, we go to the rehab coordinators and ask them, can you kindly clarify this? And once they get back to us, then we have the information. And then you at times you will have to dip into other MDT members as well. I've put them at the bottom there. The TBI nurse, traumatic brain injury nurse, and if there are discharge issues and if there are safeguarding issues, then the social worker is really important there. And then in amputees, the prosthetics team. In our trust, the prosthetics lead is a physiotherapist. Anytime we get an amputation patient, we immediately email her, and then she's really good at supporting us from the initial stage itself. And then the speech and language therapist. They also do a lot of work. The nurses will refer them there. And then I left this intentionally, the psychological medicine. So major trauma, we have our own, I don't know if it's own or part of a team, the psychological medicine consultants. Now, they are an integral part of the team where if you cannot build a rapport with the patient, if there are barriers, imagine that a patient jumped off the bridge and has major trauma. You go for 2 or 3 sessions and you're not gaining anything. The patient is refusing, you're not getting consent, and participation is very, very less. So we immediately escalate it. Normally they follow as well. We escalate it to our psychological medicine colleagues. We have consultant psychiatrists, and we also have a clinical psychologist. And both of them, they are really good. They come talk to the patient, and then they also provide us with advice to the therapist. Plan it this way, make sure that these medications are done, and this is what you need to establish with the patient. Make shared goals, or they'll give us plenty of advice on how to go and care for these patients. So this is how you dip into all the MDT members and try to go for the best outcome. And then the rehabilitation prescription I mentioned earlier, it's if you Google Rehab Prescription UK, you will find several models there. Each trust is coming up with their own documents, and these are go from 4 pages, and I've seen ones up to 12 pages. Now, whether this is improving the care, we don't know. There hasn't been any literature on that, but in our trust itself, we make sure that we complete them, and it's part of the best practice tariff. So sometimes, unfortunately, it works as a tick box exercise, but I like to do it. And when the next person receives it for the ongoing care, they actually have all this. So there's a core data set on this. All these 8 sections should be there in that rehab prescription. Now you can keep them in 3 pages or you can keep them in 12 pages, but this is what should be there. So this is initiated at the admission, and the rehab needs identified in around 48 hours. If it is feasible, our rehab coordinator normally comes and has a chat with the patient, and they initiate it. Sometimes our doctors themselves initiate the rehab prescription. And this, before it goes out to, some trusts do it as a patient open document where you actually give it to the patient, and some trusts don't do it, I've heard. So this should be signed off by a Band 7 clinician or a rehab medicine specialist registrar. Okay, now we come to the therapy aspect of it. If you have any doubts so far, kindly jot them down, and we're going to be 15-20 minutes more, that's it. Okay, the initial therapy assessment itself, now it's major trauma. You want to have all of the information that you need before going to the patient. And the place where you can get all of them is actually the notes review. You can either requesting remote control. Why does Shaheen want to control my screen? Okay. Notes review. This can be the physical notes itself in some places. For us, we have both the physical notes and the electronic patient records. So review, understand what the patient has gone through, and operation notes, post-op instructions, movement restrictions, all of that. And then the handovers, as I mentioned earlier, getting a good nursing handover is really important. They'll be able to tell you how the patient has been overnight, the physiologically how they've been, and in terms of behavior, how they've been. Sometimes the best thing to listen to is you go to a staff nurse and they say, oh, you're going to meet the loveliest person. That's really good to know, because they know that. And then you can plan your therapy, you know that it'll be a good session. And then also manual handling risk assessments in an area where there's staff shortages and everything. You will have to make a very good manual handling risk assessment. Now, if there are patients with, in the next point, multiple attachments, you have to make an informed decision and a risk assessment that I will need 2 people. This is a 2-person job, or this is a 3-person job. So you don't want to hurt yourself and you don't want to hurt the patient. So you have to make a good manual handling risk assessment. So there will be multiple attachments, the catheter, an indwelling catheter, patient-controlled analgesia if in the case of polytrauma, and they may have an epidural going in rib fractures. You might see an intercostal drainage coming out, and you'll also see vac dressings on wounds. So sometimes when you go to patient, there'll be around 6 to 7 attachments altogether in severe polytrauma. So you will have to actually look at the environment and work with this. If you pull out something, that's the most embarrassing thing to do for yourself and the worst thing to do for the patient. So your manual handling risk assessment should be really important. And then observations. Even if you do see observations on the electronic patient's record, it's always good for you to have your first set of observations there. Blood pressure, if they're on oxygen, what's their, how much they're saturating, and other vitals. And then have a good look at the chest. So normally in polytrauma, people falling from a roof or something, it's highly likely they have rib fractures. It'll by this time you'll know all of these things, what injuries are there, and if they are on, if they need any intermittent positive pressure breathing. Normally, how we identify this is our ITU therapist. They actually hand it down to us, saying that this patient responded really well to their secretion management with intermittent positive pressure breathing. So if they say that, then we also start supporting. Or they may actually develop more secretions here, we will have to initiate that. And the level of oxygen support therein, and the secretion clearing mechanisms itself. Now with the IPBV, if they haven't, if they're able to cough it out, that's fine with that. But then sometimes you'll have to give them some expiratory support as well. You can use a cough assist there. And then you assess whether they are drowsy or alert and why they are like that. If they are drowsy, if their GCS is low, and if they are alert, some people might be hyper alert in a euphoric state, multiple attachment, multiple fractures. They may be in a state where they're all happy. That's not something that is normal. And then introduction and explanation of the rehab pathway itself. Always talk to the patient and tell them what you're doing. A lot of the time when patients complain, one of the things that they complain is that I wasn't told what was done to me. That you could avoid so many, you could avoid complaints, you could avoid so many litigation. Just talk to the patient and tell them what you explain who you are, your name, and what's your role, and then explain what you're going to do with them. And And you can also explain the rehab pathway. I like to mention it very early on, but you have to balance that as well. On the very first day, going with multiple traumas and telling them that our eventual goal is to get you home on the very first day, you have to balance that scenario. Some would be really eager to go back home immediately, but for others, you might want to introduce it to the second and the third day. Okay. Then hello. Yes. Short-term goal setting and then long-term goals. Now, all of our therapy sessions are based on goals. You just cannot go and endlessly start giving therapy. You have to make on this day, by this day, I want to do this. Let us do this with. When you talk about shared decision making. So on this day, today, our short-term goal is actually to see if we can transfer you from the bed to the chair. So the goal is very clear, and it should be a kind of a smart goal. The goal is clear. The patient knows what's going to happen. You know what's going to happen. You know how many people are required. You know what equipment you're going to use, and everything is in the known there. There's no unknown element there. So a goal setting is really important. And then it should be culture specific. Sometimes you see the cultural phenomenons in the NHS as well. Now, in India, we have that thing about the bed rest, where sometimes patients, not the patients' relatives will say, oh, it was just today that yesterday he had his surgery. Why do you want to get him out of the bed today? So there you have to put your education hat on and start explaining to them the benefits of early getting out of the bed versus late getting out of the bed. And then the long-term goals, they also need to be culture specific. Long-term goals, start talking to them about second or third there. You'll get polytrauma patients out of a motorbike accident. And one of the long-term, even if they deny it at that stage, one of their long-term goals is actually getting back onto the bike and riding it for leisure. Now, if they actually bring up that topic, you can mention that it's very early to talk about that. But our eventual goal is, if that's what is one of your goals, is to get you back to do that. But I may not be involved with that. Later on, outpatient colleagues will be involved with that. But goals should always be discussed. Okay, and the next thing itself, the therapy components. Who is Shaheen? He is requesting to control my screen. Bala. Okay. Can you hear me, Bala? Hello? Can others see me? Can you hear me?
Yes.
Yes, sir. Yes, sir.
Oh, okay. That's fine then. We'll keep continuing. I think there's a power failure in Changa. Yes, we'll keep carrying. Okay. And nobody missed anything, did they? Did I go through all the slides with you?
Yes, sir.
Okay, fantastic. Yes.
It's all well,
okay.
sir. Keep going, sir.
Yes. Okay. So again, I want to emphasize the fact that it's the multidisciplinary team. So you're not an individual person, and have discussions with colleagues. Okay, let's go and do this to this patient. These are the people who are going to be involved. And then an important therapy component would be the chest management. Now, sometimes people ask me, like, as orthopedic physical therapists or as trauma physiotherapists, are you supposed to be chest specialists as well? I normally tell everybody that as an undergraduate, we learn everything, and we do specialize, but then every therapist should be able to do a basic chest assessment and be competent with basic chest techniques. Now, in our case, what happens is we have our own trauma respiratory competencies, and we complete that, and these are signed off, and then it is said that we are. But our respiratory skills are definitely much lower than the respiratory skills of our colleagues who work in acute respiratory units or the ITUs itself. Okay, and then assessment. We all know that before we go and touch a page, we have to do the assessments. So neurovascular, pulses, sensation, and then you also go with a plan for range of motion and strength exercises. These are some therapy components. Now, it's difficult to tell you which ones to give now, because it's entirely dependent on what the patient, what kind of injuries they have. So you will be starting off with some active assisted exercises, and you'll be going into active exercises. Passive, we try to avoid it as much as possible, because it has very limited relevance, passive exercises. And transfers, that's a very important thing. You should establish some method of manual handling for transfers. You can use mobility aids for that, but one of the major things is for us to get the patient out of the bed. It is not only those transfers, it's also the bed mobility itself. How to turn the patient, but that information already you would get it from the nursing staff who would have actually cared for the patient overnight. And then we include components of gait training. Again, I don't want to tell what gait training to use, because basically based on the weight bearing status of the patient and the movement restrictions of the patient and how well the patient is, we will choose what to do. So initially we start to transfer from bed to chair, and then you can include a gait training session as well. Now, a lot of the times our patients require wheelchairs. If we don't anticipate them to start mobilizing, or due to restrictions in weight bearing or movement restrictions, if we don't anticipate them to be mobilizing in the next couple of weeks, as early as possible, our occupational therapists, they come and assess the patient for wheelchair, for seating, and get them out of the bed as early as possible. And then for ambulation, so what methods are you going to use to get this patient to walk? So again, identification of appropriate equipment, identification of proper manual handling there, all of these come into play. And then another important therapy component is the discharge planning itself. So one of the questions that I ask many is that when do you start discharge planning? Basically, my concept is that you start discharge planning the moment you know about the patient. So in that first notes review that you did, it might be 6 weeks down the line or 2 months down the line, but you start thinking about it from your initial assessment itself. One of the first things that I look for is, where are they from? Are they from out of county? Are they from home? How they're living? So in the social history, you will get a lot of that. So discharge planning, whether they are going to go on to specialist rehab, or whether they are going to a community hospital, or then we have other beds called as short stay bed, and then or whether we are aiming for home itself. So these are some of the things that should always be in your mind when you actually talk to patient. Sometimes I throw the word home as early on. I tell them, so what you need to do to get home is this. So we make it very clear there. So it's acute, very acute rehab. And then you know that this patient is not going to be able to do certain goals for the next 2 months or something. There's no point in talking about walking a mile and things like that. So what you want to do is first talk about what level of function do they have to do to get them safely home. And it would be, so one of the questions, how far is your toilet from your bed? If it is 10 meters, what we should aim for is an endurance of around 20 meters for them to get there back safely with a mobility aid. And keeping them in an acute rehab setting for them to do, okay, today 20 meters, tomorrow 25 meters, then 30 meters, it's meaningless. It's not an efficient way of doing work. So that discharge planning thing is really important. And then something really important is the follow-up. Now, you actually have a duty of care to hand over your care to the ongoing team. Now, this can be in the form of a verbal telephone handover, but it can be in the form of the rehab prescription itself. So that's why the rehab prescription should be in detail, so that the patient who is receiving, the therapist who is receiving this patient has all the information that thanks Pumudra, all the information that they need to care for this patient. So imagine it like this: if you are getting a patient, a complicated patient from another therapist, all that you would expect to know about that patient, and for them to tell you, you give it to them. So if you consider that, then you will actually put in sufficient information there. So these are the therapy components for major trauma patients that we include. And then we go to the next one. What are the mobility aids that are used? I would like to credit all the company sites where I took the pictures from. So this is what we call as a Zimmer Frame here. It's like Xerox. Zimmer first started it, and then there are different companies. So this is you can call it as a two-wheeled frame and two ferrules at the back, and then we have the four-wheeled walker. This is what we call as a gutter frame. If you look at that gutter there, if a patient is non-weight bearing through the wrist and the surgeons don't want them to load axially, then you can use this. And this is what we call as a Sara Steady. This is a very good equipment, and we use it for patients who are struggling to stand up for a long time. If you look at these paddles here, these paddles, they open up. So the patient stands up holding on to this horizontal bar. And then if they are able to stand up for a brief 5-second period, we can get the paddles in and they can sit on that. So it's easy to, and then you move the whole equipment around. It's a 2-person job around to get them to sit on the chair. Now, this is a progression from there. You will want them to stand for the duration of your turn, of the turn, because there's no place to sit there. So some nursing homes use this, some residential care homes use this, others don't. But this is an equipment that's used by a lot of places, and it's a good equipment. And here you can see a wheelchair. I purposefully put this picture because it has an elevated elevated leg rest. Now, the difference between having an elevated leg rest and not is if you look at the turning radius of the wheelchair itself. This is actually a transport wheelchair. And you have other wheelchair. Transport wheelchair means somebody else has to push it. Other wheelchairs are self-propelling wheelchairs, where the patient can use his upper extremities to do that. Now, when our occupational therapists and sometimes in the community physiotherapists also go, they go for the access visit, which is the home visit, to see if we can get a patient home wheelchair bound. These are some of the things that they look for: whether the patient is able to turn around in a spot, whether they can go to the toilet, whether they have entry into the toilet, whether the doors are wide enough, access into the house, or some of the things. Their assessment is in very detail. These are some of the things that mentioned. And then we also use another, I love the pulpit frame. It's a very good early rehabilitation mobility aid. The reason is because there's this soft padded top there, and they can weight bear through their elbows and forearms. And if they are non-weight bearing here, no, this particular gentleman is non-weight bearing on the right angle, so he's basically hopping. And the difference between this and the gutter frame is the gutter frame doesn't have wheels at the back, so the gutter frame is good to walk straight. This has good turning abilities as well. And assume that the patient is in significant trauma and multiple injuries. You're not going to be able to get this patient out of bed by all these means. Then you always have the full hoist. So this is a mechanical hoist. You have to select the appropriate sling and appropriate appropriate manual handling. It's a 2-person job. And now one thing that you should always look for in trauma before using a full hoist, if there are any restrictions from the operation note itself. Pelvic surgeries, most of the time, full hoists are contraindicated. And even in a total hip replacement, if precautions are put in, full hoists are contraindicated because this will take the hip past 90 degrees. So that's where your manual handling skills come into play. What equipment will you be using for what? Okay. Now, okay, all the care has been provided. Now, is it working? So that's a key question. Now, how would you find out whether patients are being benefited from this or not? You have to go back and do some research on that. So one of the things that the TAN, the Trauma Audit Research Network, did is in early 2014, 1 year they did a 12-month feasibility study where they gave a questionnaire, to put it in simple words, questionnaire in the hospital, postal questionnaire at 6 months to find out basically injury severity score of 15 and above, to find out how they are doing. So these are PROMs, patient reported outcome measures. And now you'll be hearing the word of patient-reported experience measures as well, the PREMs. Now, when they did these PROMs, if you look at this graph here, the blue is during in-hospital, and then the 6 months is red. So if you can look at some of the activities here, so there was a 20 to 25% response rate, which I would say is poor. Any response rate should be 65 to 70% to actually make some good decisions based on it. Okay, it included a lot of quality of life indicators. Now, if you look at this, I'd like to ask you a question here. If one of you or two of you can respond to me, do you see a huge difference between the blue and the red horizontal vertical bars here? Can someone answer me? Do you see a huge difference?
Yes, sir.
Do you actually see a huge difference? See, actually, it was kind of a trick question, because if you look at this 60% there and then 38% here, 6 months down the line, you would have expected them to be better, isn't it? If you look at usual activities here, 70% had problems there, and then 6 months down the line, still 48% are having difficulties in usual activities. And then pain and discomfort, the bars are so close together. And then anxiety and depression, if you look at that, this is very concerning. It's still there at that level. So I would say that there's not much of a difference there. So what it basically indicates is that even after all of this care, 6 months down the line, patients are still struggling. So that is something that should be always kept in mind. And that could be because of the paucity of community resources. So kindly remember that. And if you look at the other pie chart here, so 27% unable to work or they work in a sheltered workshop. Only 36% of people went back to their same work. So that's a significant, around a 70%, 65% loss of input into the economic, the workforce. Okay. That's what major trauma does to you. I'm going to skip this slide. So one of the things that when they audited all the major trauma centers, it was the peer review report in 2013. Still, there were serious concerns about rehabilitation. One of the concerns is that the reports want a physiatry medicine person who's a rehabilitation medicine consultant to head the rehab in the major trauma center. Now, this is a rare breed of professionals, and it's very rare to get them. So time and again, they advertise, but they don't get. That's one of the things for serious concern. And other than that, it's a lack of a rehabilitation trauma coordinator or lack of other rehab resources. Okay. Now, how did we do? The JohnRadCliffe Hospital in 2013, we didn't do well. We came under the minus category there. And if you look at the St. Mary's Hospital in London, they're all greens there, and a 93% when it came to rehab itself. And if you go online, you'll get this report, and we were 64% there in the red region. And there was another peer review done in 2018. I couldn't get hold of a report there. And since the earlier queries were the same, we had the same queries now as well, but we do have rehab coordinators. Might be a minor change. I'm not sure about that. Okay, 10 minutes on the Indian perspective. Now, I picked up two particular articles. Happy that still there are 80 people around. I don't want to lose you. Another 10 minutes, okay? I picked up two or three articles to actually highlight that. Now, one of the participants early on, they mentioned about can major trauma be a specialty? Like all the data here suggests that it should be a specialty. Like it really should be a specialty. We need more and more people getting into major trauma and working with these patients early on. Now, because I'm talking the Indian perspective, I worked for around 10 years in India, and there's been leaps and bounds of growth. So I had to talk to a few people to get the Indian perspective, what has happened in the last 10 years. And there have been some really interesting changes. So the first study was done about they just looked at it, all data on what's happening. So trauma care systems in India and China, a grim past and an evolving future. As the title indicates, it is really grim data. If you look at it, approximately 6% of all the global road traffic accidents happen in India. And even though it has only 1% of the world's vehicles. Okay, other data, 35 per thousand vehicles meet with an RTA, and the fatality rate of 25.3% per 10,000 vehicles is the highest in the world. Okay, and then if you look at this, how much it has increased. In 2015, road traffic accidents were, what is that, 1,39,000. And then it keeps moving by another lakh in 2015. And then the proportion of fatal accidents in total road accidents in India has gone up, actually 18.1% in 2002 to actually 24.4% in 2011. So quarter of the population in the road accidents, they actually die. So similar to other parts of the world, the road traffic accidents, if you look at that, it's mostly the younger age population who actually drive the bikes, go in the cars and go to work, back from work. Yeah, and the data is that 68.6% involved in those between 18 and 45 years. If you look at that particular group, it is the group that is earning. Imagine that if they are the breadwinners of the family, that family is doomed if something like this happened, and if the person passes away or if they have lifelong disabilities. Now, one of the things that you look here is that I'm mentioning only about the road traffic accidents. I'm not mentioning about other trauma that can happen because of falls, that can happen because of work-related incidents and things like that. So if you add all of that into the element, it is going to be more. And then, as I mentioned, my first slide, the study where they examined trauma deaths. Here they examined a group of researchers. They examined 2,500 trauma deaths in India. So what they did is they wanted to look at the opportunities whether these in-hospital deaths could have been prevented or not. So what they did is they categorized them based on the ISS. So they are called mild 1 to 8, and then moderate, severe, and then profound. Okay, and then when they actually looked at the 30-day this, so during an 18-month period, there were around 11,500 trauma admissions, out of which 2,523 people actually died. So if you look at that, that's actually coming to that same percentage that I mentioned earlier, around 20 to 25% who die. So 21% of them, there were deaths. And when they looked at those deaths, the overall proportion of that was that 58% were actually preventable. That is, half of those deaths could have been preventable. Now, imagine this coming out in the newspaper, like how the headlines will be if the media got so basically what they will say is, if you have an accident, you have a 50% chance of survival, which is not good at all. And telling this to the families, it is not good at all. And then in a mild ISI score, 71% of deaths were preventable, and that's actually the data. So what they identified is that there are system-related issues, including lack of protocols, lack of adherence to the protocols if the protocols are there, pre-hospital delays, and then delays in imaging. All you have to do is that you just go on YouTube and look at ambulance traveling on the road in a developed country and an ambulance traveling on a road in a developing or underdeveloped country. I don't want to mention country names. You'll find a major difference there where that golden hour is being missed there. People have complete lack of regard to an ambulance or a blue light vehicle, and every minute that's ticking there is leading to life loss. So that's what this article said. Now, amidst that grim data, there's also a lot of good things that are happening. So what happened is in 2013, if you look at the date here, India and Australia, they teamed up, and the Australian government spent around $2.6 million and funded something called as the Australia-India Trauma Systems Collaboration. Okay. Now, what this is basically, if you go onto their website, it will mention the work that they are doing, and they're actually doing a lot of work. Now, falling back into existing strength of research is so important when you work on. Now, physiotherapy is actually a physiotherapy or medical science research itself is kind of you can say in his nascent stage there, 50 years kind of thing, 50 years. But there are other specialties. Now, if you look at this professor is Venkatesh Balasubramanian. He is a PhD and a professor in IIT Madras. How he contributed, if you go to his website, you can look at how he contributed to healthcare and how he made changes and contributed to developing this system called as the TE, they call it as the TE in Tamil Nadu. So in collaboration with this Australia-India partnership and the National Health Mission, just in Tamil Nadu, they came up with a system called as the Tamil Nadu Accident and Emergency Care. So early work was, and this is not there in other parts of the country. It could be if they study the systems used for this model, and if it is successful, then it is worthwhile implementing. Basically, early work was done in 2016, and they piloted it in the Madras Medical College, which I believe is called Rajiv Gandhi Hospital now. Piloted it for 6 months in 2018. So basically what they did is they categorized in the ED, treatment can be safely delayed, which is the green zone, priority 3, and then potentially unstable, urgent and immediate care, priority 2, and then in red. The other was yellow. And then red, airway, breathing and circulation is compromised. They receive priority 1. Now, in the center, I've put out what was different to earlier. So same emergency department, but changes in the processes and the workflow. So there was a pre-alert from the 108 system, which has revolutionized Indian emergency care to a certain extent. Imagine, if you don't believe in that, imagine before that and after that. So pre-alert on a dedicated phone number from the ambulance staff, no question of the phone getting engaged, to the hospital to tell them that this is the patient and we are on our way. And then triaging in ED to different zones, which are these zones, and then CT and reports immediately. And this pilot program was done from January 18 to July 2018. Now, lives saved Yes, based on this data, if you look at this, it's a small slide, but I can link you to the newspaper articles. The thing is, it's only newspaper article, so we can only believe the data that they give. It's gone from the hospital. So out of a total number of 1,900 cases in January, the percentage of deaths was 8.27. But when it went to July, out of 1,600, similar number, the percentage of death was 4.89. So the amount of deaths went from 157 to 81. So in that particular period, the deaths were prevented. Now, if you say that this is a small number of deaths that were prevented, try telling that to the patient's families, and they would say that each individual life matters. And that was in 2018. And then in 2019, this is another newspaper article. This is a Tamil Nadu health minister, Dr. Vijay Bhaskar. You would have seen him for the Corona news. He also happens to be our school alumni as well. So he has again declared another 20% down in the fatality rate, and provided more funds. Now, why I wanted to highlight this data is because in major trauma, if a patient survives, it's not the end there. That's when rehab professionals start kicking in. Sad to say, if the patient dies, you have no role there. But once they survive, you have a huge role there, and your role may be starting off in the acute care and may go on to a year or so. So there's a huge opportunity there which needs to be tapped into. And I'm not sure what is going on there in terms of government physiotherapists going into acute trauma wards there. Okay, now there was a now as earlier, you should study the systems if it is effective or not. And in the Coimbatore Medical College, they actually did a study, but they mostly on the TAE system, but they mostly I looked at that paper to find out the processes, because they looked at implant surgery before and after ORIFs, which is not relevant, very relevant to us. But this is the difference between elective procedures and the TAE itself. Blood investigations, you get them within, you send to the 24-hour lab and you get it within an hour. Radiology investigations, immediately within an hour. Cardiac evaluation, immediately, because the whole team, I had a chat with my friend who's an orthopedic surgeon. He said that the whole team will be ready for that. And anesthetic assessment, immediately. And these are there in words here, and it affects the length of stay as well. Surgery time delay from admission time in days, nil. That's actually remarkable. If they need, if the acute assessment is done and they need theater, immediately the theater is arranged for them. Now, this is all mentioned in writing, how much it's happening. Your colleagues in Tamil Nadu can actually share and have a look there. Now, yes, so that's the end of my slide. And here I wanted to explain a little bit of a case study, and I wanted your opinions on this. How would you actually manage this patient? Okay, so you can unmute your mics and raise your hand or something, and then start talking. I know what I will do for this patient, but what I wanted to know is what you would do, what your discharge planning would be. So 25-year-old motorcyclist, head-on collision with a car, polytrauma. It's a fiction. So there was an open reduction in internal fixation done on the right acetabulum. So if you look at the post instructions, weight bearing for transverse only for 6 weeks, and then no hip flexion past 90 degrees for 6 weeks. This is a common instruction we get for acetabulum, badly damaged acetabulum and fixed acetabulum, so that the head does not go past 90 degrees and put too much pressure into the metalwork of the fixed acetabulum. Of the left tibial plateau, this is the contralateral limb, non-weight bearing for 6 weeks, and only 0 to 30 degrees of movements, knee flexion for 2 weeks. This automatically means that you put them in a range of motion brace. And then ORIF of the right distal wrist fracture, for a wrist fracture, non-weight bearing for 6 weeks, but can weight bear through the forearm like that. And then you can also initiate range of motion at 2 weeks, and you can also use that hand for personal care. Sometimes when our trauma consultants give these instructions, they actually look at the patient in the totality, because if you go individually and give instruction, we won't be able to do rehab at all. They consider us as well when they give those instructions. And even if the instructions are given, if after our first session of physio, when we talk to the surgeons, they always give a ear to us and mention that okay, we can relax on this, we can relax. But sometimes if there is, based on the confidence that they have in the fixation, they'll clearly tell us that no, this patient non-weight bearing for 6 weeks, and we have to abide by that. And then multiple rib fractures, there's also an intercostal chest strain in situ, previous history of depression and anxiety, lives alone in a house with upstairs bedroom and toilet, limited support network, normally works as a roofer. So I've made a fiction out of this, but these are some of the patients that we normally get. And that's why the MDT is so important, and thinking from so many different directions. What I want you to do is take a piece of paper and then maybe look at what you would do, rehab goals. So these are some of the things that I would do. So does anyone want to answer this and share some of your experience, and then we can go into questions. So this is, I'll leave it on there. This is the case study that I want to discuss. I'm mostly done with my presentation. So let's actually open it up. So this is a case study. So what would you do in terms of these things? So what you want to talk about is chest management, pain management, bed mobility, transfers, mobility, discharge planning, onward referrals. So what would you actually do for this kind of trauma patient?
I think the session is open for the participants.
Yes.
To respond to the question. The case scenario has been given. So you can put a point that what will be your plan of treatment? What is your preference of treatment for this case?
Basically what I wanted to know is what would you do in your local setting?
I think first of all we have to categorize the plan of treatment, whether which is emergency or which is kind of thing which we want to go for first. Like you can think about like categorizing the priority of the goals first based upon the case.
Yes. So when we triage these patients in the morning, we would definitely triage this patient as a high priority because they have chest injuries, and them staying in bed for longer would lead to several bed-related complications, like a hospital-acquired pneumonia or a DVT or things like that. So we would prioritize them really high. So what else would people look at? Like in terms of chest management, what would you want to look at? Because I did mention that the patient has multiple rib fractures. So what would anybody want to look at the patient's ability?
Is there anybody who would like to respond? You can unmute your mic and then you can
unmute your mic, and
video
it's all a learning experience. I just want to know what you would do in your local setting.
I think being the chest infection, the foremost thing that we have to go for the morning, the first the drainage of the secretions, and then you can go for the assistant, the breathing system, the initial part for them.
Yes, Bala. So
that is the first foremost priority, to make them breathe on their own, or we have to assist them, the breathing system kind of thing. Remove the secretions. So once the chest secretions are getting cleared, I think then they will be able to cooperate for the further intervention for the next process, whether the mobility or the kind of things.
Yes, yes, definitely. So that's why I put that at the very top, the chest. So the chest management takes a huge priority here. There are, and one of the things that you would immediately check is if the patient has an independent cough. If they have an independent cough and if the chests are clear, then basically you can tell them that you keep practicing and then you teach them breathing exercises and ask them to keep practicing that. And then this is what I would do. Then moving on to pain management to sufficiently see if the patient is having sufficient pain management, because there are multiple injuries here. So without appropriate pain management, we are not going to gain anywhere. And then I would look at bed mobility itself. What is the capacity of the patient to roll? Because that would facilitate nursing care. And then when they can move or turn around in bed, that will facilitate the next stage of transfers. And then when it comes to transfers, I will look at what kind of mobility aids I would need, the manual handling assessment, how many people I will need for that. And then I will start to, and then for mobility in this particular patient, I'm not going to concentrate more on mobility here. If you look at the previous slide there, there are several restrictions here. You cannot weight bear on the left lower extremity, and you can only weight bear for transfers on the right lower extremity, which basically doesn't give us much of a leeway there, because you can't weight bear for only transfers when you're non-weight bearing on the other side. And then you could technically get them to stand, but where that will become a problem is the no hip flexion past 90 degrees. So initially I would go with a sliding board transfer using good left limb and several assistants. So getting the occupational therapist in as early as possible and then going for transfers as early as possible would be the goal. And the patient would also need a wheelchair with a rest, leg rest, because of the 30-degree knee flexion precaution. I just threw all of these things into complicated. And then when it came to the discharge planning itself, in India, normally we have a lot of support systems in place. Family to help, we have intergenerational living. So there'll be plenty of support. But in this case, I've mentioned that he is a loner, not a lot of social support. So get the social workers in, and if any care has to be done at home, it can be done. But based on all of these injuries, I see this patient going on to another hospital, a community hospital or a specialist rehab hospital, to get more rehab and then go home from there. And I look at this patient staying for around a week with us. And these are some of the things that we'll be doing in that first week. Okay. Anybody else, if you want to comment, you can comment. And I'd like to open for questions now. And then if you can also note down my email ID there. In the past, I have put all the articles that I use for the presentation, and not a lot of interest. So if you have interest in reading these papers or the abstracts itself, I can't, if it is a copyright protected, I can't email you the whole article. I can email you an abstract. Kindly email me, and then I'm more than happy to take the discussion forward. And if you have any questions, we can open it a little bit out here.
I just want to put a question into the patient case.
Yes.
In the pain management, like you said, like they are having already existing the previous depression and anxiety.
Yes.
And they are living alone in the home.
Yes.
So what type of pain management you focus for those kind of patients?
Yes.
Go for the modalities, or you go for the counseling, or you go for the education?
Yes. So for acute pain management, in this case, there might be that the patient, because of the multiple rib fractures, they are already coming into the ward with an epidural where pain medication is infused constantly because of the rib fractures. But if not, you can expect this patient to be on what we call as a patient-controlled analgesia system, where they press a button for every 5 minutes to get that pain medication. And then once you wean them off from there, you can get them onto oral pain medications as well. Now, I know we talk about pain as the whole biopsychosocial model, but what cannot be ignored is that you can start talking about that. There are physical reasons for this patient's pain, and it has to be addressed there. And also, because I threw in that depression and anxiety thing as well, pain is how we perceive it, and this patient might actually be perceiving it in a different way. So we have a specialist team called as the pain specialist nurses, advanced practitioner nurses. They are really good at this. They come immediately and then they support the pain management. As Bala mentioned, in the community, when the patient is getting discharged, they will be going in with the supportive pain medication. But then the acute pain medication pain team support ends during that when they go in for the community. It should normally be supported with the general practitioners, either in the form of oral pain medication, or counseling is a good thing to do. That's one of the community resources, and a lot of the community resources are scarce. But if we have concerns, we can actually refer them to the community mental health practitioners.
Okay, thank you.
That answers your question. Somebody wanted me to go a little bit fast. I really apologize. I wanted to.
You can close on the screen, sir, in sharing, and it is open for questions.
Stop the share there. Okay.
Now it is open for the forum to ask any questions if you got it. Because as of now, I have not seen any questions in the chat thing. Yes, sir.
So there's all mentioned from a fourth year BPT Saloni, due to multiple rib fracture, we can say paradoxical breathing pattern too. I did not mention that. You get the paradoxical breathing when you have a flail segment. So in this case, it might not be the case. Yes, but that's a possibility too. Yeah. Any other questions, please?
Yes, sir.
Yeah.
Sir, I need to ask that as a rehab team manager,
yeah,
who is going to be that chief post of rehab team manager?
Okay.
Is it
that is a
or someone else?
Yes. So that is a very, very valid question. And I can ask that in the Indian context, that's a valid question. That's one of the reasons why we put it as an MDT, the multidisciplinary team. So no one actually, I presented briefly in my presentation as well. No one is the head of the team. So we can say that the rehabilitation coordinator plays a huge role in coordinating all of these activities. So they can take the lead, and at different times, different people will be taking the lead. So obviously during the surgeons have to do the surgery, and a lot of the time in the ward rounds, what our trauma surgeons say is, I've done my job here. Now it's up to these gentlemen, the therapist, to actually get you safely home. So it will keep shifting. So there's no real head there, but the responsibilities, one responsibility will peak at one time and then go down at the other time, and then the other will peak. So it's actually a team effort. But when it comes to formal meetings, there will always be one person who heads it. It again can be either a rehab professional or a doctor himself. So that hierarchy fortunately is not there in UK, where everything has to go through one particular person. I hope that answers your question, Drew.
Any
Yeah.
other questions from the audience? Any other questions from audience? So there is a question in the chat box.
Yeah.
What about the urinary incontinence? Isn't
Yes.
trauma may cause urinary incontinence, and when will start in the rehab goals?
When will the second part of the question?
And when will start in the rehab goals? How to manage urinary incontinence?
Incontinence. Okay. So trauma. I did not mention that aspect. We do get our spinal injury patients as well, and in those conditions, if bladder and bowel dysfunction is there, we have specific protocols on bladder and bowel training. So the nurses generally they initiate those protocols. Now, if it is as part of an abdominal injury during the trauma itself, then we actually seek urologist's opinion. That's one of the things of being in a major trauma center. You immediately seek for urology opinion. Recently, we had a patient who had I think a urethral injury or kidney injury, and they had specifically, urology had requested bed rest for a couple of days. So in terms of that management itself, so it's guided by urology there. But if it comes to spinal cord injury itself, the nursing staff actually manage that, the bladder and bowel protocols. So in specialist spinal injury units, I think therapists also, they get involved in that, but not in our unit.
I think being in the trauma area of rehabilitation, that everybody's role has been defined particularly. Am I right? Each and everybody has to have particular role that with the focus of early management.
Yes, Bala. So that's where again I would like to come back to the MDT. So your role is defined as a therapist, and occupational therapists are there. But what happens is when you're actually in the thick of the ward, some roles do get blurred. Now, when that happens, you have to stay within your competencies, within what you're competent to deliver. You cannot go and deliver an IV or something, or giving a medication to a person just because a nurse is there, not there. So that shouldn't happen. We have clearly defined roles. Now, what I would like to tell you as an example is sometimes when we work in collaboration with nursing staff, as therapists, when we are doing a therapy session, we are going to try and roll a patient or something. If the patient has a bowel movement or something, so there the roles get blurred. As therapists, we assist our nursing colleagues in personal care. We help them out, and then they in turn help us to get the patient out of the bed. So there will be a lot of shared responsibilities. And when you're working in a unit like a trauma, you cannot go and say that this is the only role I will do. So that will not work. We have to support colleagues. We have to support each other, but also we need to stay within what we can actually, what we are professionally eligible to do.
Thank you, sir. Any other questions from the audience?
Any other questions? I know I took a lot of time earlier. There was the technical difficulties as well. I had planned this as a 90-minute session. I think that's what we are 10 minutes or 15 minutes over 90 minutes. But thank you so much for arranging it, Bala. Thank you to your institution, and thank you to all those participants who came in. If you're feeling a bit shy to put your questions here, I shared it on Facebook as well. You can also ask questions there, and I'm very happy to explain it further. But what my request is that take it forward to the hospitals and explain the role. And I know changing systems is difficult. That's where individuals come into play. Take it forward, and association should also come into play and take it forward. And this is our role, and we should. There are people who are doing, because when I yesterday spoke to Dr. Murthy sir, he explained the kind of work that they are doing in the AIMS. Is like, I was actually astonished on the amount of work that they're doing. But nobody else knows it, because unless they publish and tell to the country that this is what they're doing, others won't know that. So propagation of the good work that you do is also really important.
Thank you, sir.
Thank you.
I think we can come to the end of this session.
Yeah.
I'd like to thank you for the valuable time. So we got some interruptions between 2 times the light went and came, and then
I didn't realize it the second time.
Yeah, we were lost and we came back. And thanks for somebody who was co-hosted the process. It was not disturbed. And second part is that I'd like to thank all the participants for being here. And it's a very honor and privilege to have you, sir, on behalf of this webinar. And we from the University of CHARUSAT University of Science and Technology and Ashokan Vidyapatil Institute of Physiotherapy, a Constant Institute, would like to thank from our wholeheartedly for sharing your experience on the trauma experience which you are facing and then which you are working on, the multidisciplinary team from the UK as well as, and you would try to give us some more information about the process which the Indian Australian government has taken it, and then how the Tamil Nadu government is working on those processes. Let's say that this is, once again, this is an idea of us to get an explore of the how being a physiotherapist who is working in the trauma, which is normally untouched, mostly because we work on the more of the outpatient. Still, it's another area which we can focus on to save these more lives. So we'd like to thank once again you, sir, the participants for being part of this program. Thank you, sir. Thank you very much.
Thanks, Bala. Thanks. Bye-bye. Thank you.
Thank you, sir.